to the management of Trichomonas vaginalis. So Trichomonas vaginalis is a flagellated protozoa. Organism is found in the vagina, urethra and paraurethral glands. Urethral infection is present in 90% of women, although the urethra is a sole site of infection in less than 5% of cases. So most commonly it is urethral infection is associated in many cases, but isolated urethral infection is not very common. Transmission is in adults, transmission is almost exclusively through the sexual intercourse. Okay. Now, what are the symptoms? In females, the symptoms 50%, 10 to 50% females may be asymptomatic. Common symptoms are vaginal discharge, vulval itching, dysuria, offensive odor, but these are non-specific for Trichomonas vaginalis. Occasionally, the presenting complaint is of low abdominal discomfort or vulval ulceration. In males, 15 to 50% of men may be asymptomatic and they usually present as a sexual partners of the infected women. Okay. The commonest presentation in male is urethral discharge and or dysuria. Other symptoms will include urethral irritation and urinary frequency. Patient may complain of a copious purulent urethral discharge or complications such as prostatitis. Now, what are the signs? Vaginal discharge is seen in 70% of cases. The consistency is variable from thin and scanty to profuse and thick. The classical frothy yellow discharge occurs only in 10 to 30% of women. Okay. There will be associated vulvitis, vaginitis. Approximately 2% patients will have strawberry cervix. I have mentioned only 2%. This remember, this strawberry cervix is one of the important word when you deal with Trichomonas vaginalis, but it is seen in only 2% of cases. Okay, this appearance is seen on the naked eye. Higher rates are seen on colposcopic examination, and 5 to 15% of women will have no abnormalities on the examination. In males, urethral discharge will be present in 20 to 60% of cases, usually small or moderate amounts only, and or dysuria. Male may not have signs also, or rarely they can have balanoposthitis. Okay. What are the sites which from where you will take the swab? Now, in cases of females, you take the swab from posterior fornix. Remember, Trichomonas vaginalis, posterior fornix. It is a self-administered vaginal swab. We will also give equivalent result. Even if the patient can collect her own swab. Urine has been used for evaluation with some nucleic acid amplification test. Okay. In males, urethral culture or culture of first void urine (FVU), first void urine will diagnose 60 to 80% of cases. So in males, it is a urethral culture or culture of the first void urine. In females, vaginal swab taken from the posterior fornix or the self-administered swab from the posterior fornix is the sample of choice. Then coming to the diagnosis of Trichomonas vaginalis, microscopy, vaginal discharge, plus drop of saline on the slide, on a slide, cover with a cover slip and see it under the microscope. Initially you will see under the 100x, then you will see under the 400x. Okay, you have to see that particular slide within 10 minutes of the preparation. When within 10 minutes of this, that is actually point of care test. Sensitivity is highest in women presenting with vaginal discharge, and a visualization of motile trichomonas in these women indicates the presence of infection. However, the sensitivity is low, it is 45 to 60%. Okay, so microscopy sensitivity for trichomonas vaginalis is only 45 to 60%. Culture of Trichomonas vaginalis has a higher sensitivity compared to microscopy. Culture was considered the gold standard, but molecular testing has proven to have a higher sensitivity. So initially they used to say the culture is gold standard, but nowadays they say the nucleic acid amplification test (NAT) is the gold standard test. So if they ask you the gold standard test for TB, then it is a NAT. Okay. Coming to the general advice, sexual partners should be treated simultaneously. Patients should be advised to avoid sexual intercourse for at least 1 week. Okay, here you have to advise the advise the patient to avoid the sexual intercourse at least for a week, and until they and their partners have completed the treatment follow-up. Here recommended regime is metronidazole 2 gram orally single dose. That is the first choice. Alternative is a metronidazole 400 to 500 milligram BD for 5 to 7 days. Okay, so there is a difference between the treatment of ductal vaginosis and Trichomonas vaginalis. Okay, the alternative regimen is tinidazole. You can be used that is 2 gram orally in a single dose. Then trinidazole has a similar activity to metronidazole but is more expensive. For HIV positive individuals, a recent randomized clinical trial demonstrated that 2 gram single dose of metronidazole was not as effective as 500 milligrams of metronidazole given BD for 7 days. Okay, so if the patient is HIV positive, then the you have to give the treatment with 500 milligrams of metronidazole BD for 7 days. So it is a 7 days treatment for immunocompromised patient. While normal patient, it is a single dose of 2 gram first, then 400 to 500 for 5 to 7 days. That is the second. Okay. Coming to the pregnancy and breastfeeding. Metronidazole can be used in all stages of pregnancy and breastfeeding. The manufacturer recommend avoiding high doses if the patient is breastfeeding, and if using a single dose of metronidazole, breastfeeding should be discontinued for 12 to 24 hours to reduce the infant exposure. Tinidazole is pregnancy is a category C. Sometimes they will ask you what does the category C drug means. There are categories of category A, B, C, D. So what does the category C means? Animal studies have demonstrated an adverse event, but no adequate, well-controlled studies in the pregnant women have been conducted. So there are animal studies which show that the drug is harmful or there are adverse effects, but there are no adequate and well-controlled studies in the pregnant women. Okay, so animal studies are there, and the animal studies report is very clear. It is a adverse drug reaction or adverse event, while there are no well controlled studies. That is a category C, and it is its safety in the pregnant women has not been evaluated. The manufacturer states that the use of trinidazole in the first trimester is contraindicated. Okay, so trinidazole is contraindicated in the first trimester. Then what is the caution? Patients should be advised not to take alcohol, that we have seen, at least for 48 hours or 72 hours if it is a tinidazole, because of the possibility of disulfiram like reaction. Then coming to the treatment failure. Now this particular topic of treatment failure is little complicated, but it has not been asked up till now. If you can remember it, it will be better. If the scenario, especially for part 2, they may ask you, you may have a persistent or recurrent Trichomonas vaginalis due to, one, the therapy is inadequate, second, there can be reinfection, or third, there can be resistance. Okay, so either inadequate therapy is given, or there is a reinfection, or there is a resistance. So first thing what we will be doing is a check the compliance and exclude vomiting because of metronidazole. Then you have to ask the sexual history for possibility of reinfection, and ask if partners have been treated or not. So this particular thing, if the patient, if there is a treatment failure, you have to ask what is the compliance and exclude vomiting if it is a metronidazole, and sexual history needs to be asked. Then coming to the follow-up. Test of cure is only recommended if the patient remains symptomatic following the treatment. If the patient is symptomatic, then only you do the test of cure. If or if there are recurrent symptoms, then you will do the test follow-up or the test of cure. Okay. Contact tracing and treatment. Current partners and any partner within the 4 weeks prior to the presentation should be screened for full range of STIs and treated for Trichomonas vaginalis if uh, uh, results, irrespective of the results of the investigation. So how many weeks you need to trace the partners? 4 weeks before the presentation. So in last 4 weeks, you need to trace the contacts and treat those contacts irrespective of the results of investigation. Okay. Now coming to the treatment failure, this is a little complicated, but if you can remember, it will be better. A study investigating repeat Trichomonas vaginalis infection at 1 month following metronidazole 2 gram single start dose found that 7% of HIV negative women and 10% of HIV positive women were still infected due to treatment failure. So the drug of choice we have seen, it is a 2 gram metronidazole. Okay, you have given this particular dose, but at the end of 1 month, if you see that 7% of the non-HIV women and 10% of the HIV positive women will have a treatment failure. Okay. Now that means they are not responding to the single dose therapy. Now what is the treatment protocol for such patients? Okay, first thing, you will always exclude the reinfection and non-adherence. These two things you will exclude, and you will think of three possibilities or three types of different courses are there. One, you repeat the course of 7 day standard therapy. we have seen the single dose treatment is also there and 1 week treatment is also there. So in this particular case, if the single dose is failed, you repeat the course of the same standard therapy for 7 days. Okay. Then second is a higher dose course of nitroimidazole, and third is a higher dose course of tinidazole. In third, very high dose course of tinidazole. So these are the three alternatives in cases of the treatment failure in cases of Trichomonas vaginalis. Okay. So first option is a repeat course of 7 day standard treatment. So 2 gram stat is failed. So what we will do? Metronidazole 400 to 500 milligram BD for 7 days. Okay. In those here the response rate is 40%. Okay. So the first option, you give the metronidazole 400 to 500 milligram and 1 week you treat. The response rate is 40%, 40. Okay. The second option, then you give higher dose of nitroimidazole. Here again the drug of choice will be metronidazole or tinidazole, but you give it in a high dose, that is 2 gram daily for 5 to 7 days, or metronidazole 800 milligram 3 times a day for 7 days. Here also treatment is for 1 week. The drug of choice are both metronidazole and tinidazole. Okay. And the same high dose, which initially we were giving metronidazole 2 gram single dose only. Okay, so the patient had a treatment failure. So we have given 400 to 500 milligram for 1 week. Okay, then second option still not responded. In that particular, you go for higher dose. Here we will use the 2 gram dose for 5 to 7 days, and metronidazole or tinidazole can be used. Or what we can do is a metronidazole 800 milligram 3 times a day for 7 days. The response rate is 70%, 70. Okay. I hope you are getting 40% with a standard regimen, repeat standard regimen, 70% with a higher dose. Okay. Then third is a very high dose of tinidazole. Here the tinidazole is given 1 gram BD or TDS. Okay. Or it can be given 2 gram BD for 14 days. So here the treatment is 2 weeks. The drug of choice is tinidazole. Okay. Along with vaginal treatment, that is intravaginal tinidazole 500 BD for 2 weeks, and the success rate is 90%. So you can remember, one, if there is a single dose treatment failure, you give the metronidazole for 5 to 7 days. That is, repeat the standard course. 40% success rate. If there is no response, you can use metronidazole or tinidazole. Treat the patient for 7 days. Okay, but use high dose, that is 2 gram for 5 to 7 days you give, and 70% success rate. Third, tinidazole is the drug of choice. High dose is required. 2 weeks of treatment along with intravaginal treatment. Okay. So I hope you remember, you have got this. The same thing I have just tabulated. So first option, repeat course of 7 day standard therapy, 40% success rate. Second is a higher dose of course of nitroimidazole. Okay. Third is a very high dose of tinidazole. So this slide also you can take the photograph. Okay. So that finishes the today's topic of Trichomonas vaginalis. Thank you.